Good morning. Can I see you? I mean, am I audible? For those who have joined the class, am I audible to all of you? I can see 73, so I have a chat box. Yes. So both Ria and Ishika and Asta. Good. Okay. So another 5 minutes, I think I'll wait so that most of you join and we can start this class on common genetic disorders. Yeah, I think already it's 8 o'clock and we are just going to start this session. And again, today there are some chocolates and some really interesting things, some of which you must already be knowing because genetics is covered very much in the 10th and the 12th class. But what's coming new is little what I'm going to tell you and what are the clinical applications of genetics, right? So here, uh, I'm going to start with an important case, and I think what you do case wise is much better than what you remember or you mug, because whatever you mug up, you vomit in the exams, and after that, nothing retains. So it's very, very important to understand that if you have a case based approach, or if you know the exact answers, you would be where it's very, very important that you catch it through. So this is a real example, and this was a 9-month-old infant who was referred obviously to directly to genetics with the diagnosis of spastic cerebral palsy. Now, currently, this baby was 5 weeks of gestation, and obviously, the first thing that you see is the baby term. Did the baby cry after birth? And what are the day-to-day APGAR reports? So, APGAR, all of you know, is an important tool, though many of us don't do it. It'll give you an idea of how good the baby was immediately postnatally. So his APGAR at 1 minute was 8, at 5 minutes was 9, and at 10 minutes was 9, which is perfectly normal. That means there was no birth asphyxia. The child was delivered immediately. The child cried immediately after birth, was all right even 10 minutes after birth. Very, very important. And I don't know if Dr. Monica has taken your tutorials. You would know that one of the important causes of cerebral palsy is intrapartum asphyxia, or poor blood circulation and poor oxygenation to the fetal brain in the process of parturition. So now let's relook at this. So this was a 9-month-old child who was referred with a diagnosis of spastic cerebral palsy. And currently he was just 5 weeks, not of gestation, but of age. And the birth records which were available did not suggest that this baby had any problem in utero, because he came out, cried immediately after birth, was put to breast and accepted breastfeeds well. Now, this was a full term normal vaginal delivery, so nothing wrong with the delivery. They did not have a stress test which was positive. They did not actually have meconium, for which they could have done cesarean or any other indication. So he was more like any other baby by normal vaginal delivery and at a well attended center. It's not that this child was born, nobody knew the baby cried or not. So if somebody wrote a good birth weight baby with an UPCAR 9 and 9, it definitely means that the baby was absolutely fine at birth. But exactly what happened, that as early as 5 weeks of age, uh, so, they realized something abnormal. And when the child presented to us, he was spastic. That means he was having increased tone in all the four limbs, absolutely tight, so much so that it was difficult to put on the clothes on this baby. He had not attained development in any of the four domains. That means cognitive, language, socio-adaptive, and fine motor, gross motor. So any of the domains, the child had not attained any attention. Had this been intrapartum asphyxia, the Apgars would have been low, but this was not an intrapartum asphyxia. So this was something which happened after the birth, and he was then noticed to have bilateral increase in tone of all the extremities with very brisk reflexes. And since this mother was again pregnant, she was referred for genetic counseling in the next pregnancy. So now you know that all of these mothers with a small case norm, they every child is, it was earlier also important, but with a small family norm, with more and more medical diagnostics coming up, uh, the baby was an issue, and that is why he had been brought. So a detailed pedigree was taken. Now I'm going to ask the first. Yeah, there is some question on the chat box. Shall we have a look at the chat box? No, it's all whether I was audible or not, right? So the father was reported to have polio. I said, why have you come alone? Why did you not get the child's father? She said that look, the father has got difficulty in moving, and everybody told me that he had polio at the age of 17 years. Is it something alarming? Yes. Any answers in the chat box? Yes, there is one answer. Now let me see what the answer is. So, oh, only audio is there. You can't see my screen? Can you see my screen? Please write yes or no. I thought you could see my screen. Yes, can you now see my screen? Can you see the screen, dears? Okay. So I'm sorry you missed the last bit of presentation. So here, in this case, detailed pedigree was taken and father was reported to have polio. That's why he hadn't come. So my question was, what's wrong here? What is striking you that polio at 17 years? Yes. Anybody for an answer? There is an answer coming, and let's see who it is. Polio occurs earlier, that's right. Harsh has written that. And ma'am, it could have been a misdiagnosis. Yes, it was definitely a misdiagnosis. So the answers are correct, but let's go ahead and see. For those who answered that it was a misdiagnosis, yes, somebody has a hands up. Yes, this is Siddharth. I'll just see what I can. So I'm not getting anything on the chat box, but maybe I just had her hands up and maybe I'll just ask you. Now, when I probed the mother a little more further, she said that the grandmother has started swaying at the age of 65 years. Oh, we all know that people can sway at the age of 65 years. They may not be very, very stable. So let's see some other cause of AFP. Father may not have had polio. Isn't it too late for an age for polio? Spastic paralysis has been a misdiagnosis. All of you are correct. People may have named each and every spastic. No, here, no, dear. Polio is a condition in which spasticity is not there. Deba Brat. So there is no spasticity. In fact, there is ataxia and there is hypotonia, and it's usually asymmetrical. So I asked the mother, does he have a limp in one foot? She said, no, there is no limp in one foot. So, exactly what do you think? You have a child, an infant, who comes to you at 9 months of life. At the age of 17 years, the father demonstrated some motor symptoms. And at the age of 65 years, the grandmother demonstrated symptoms. So, yes, so both Ria and Nilayan again, this is a disorder which is a trinucleotide repeat disorder, with each generations having successively higher earlier ages of presentation and more severe presentation. So the grandmother, the age just had a little bit of swaying. The father doesn't move very well, and this child has in utero presentation, probably spasticity. It's the cognitive function which was maintained, but the motor function which was not working. So it immediately gets a call to the geneticist that you're dealing with a pedigree in which there is vertical transmission with anticipation. So, what was this? Now, this was a case we reported, and I've just shown you. You can go to PubMed and see this case. This was spinocerebellar ataxia. So, an infantile onset of spinocerebellar ataxia in which there are repeats, but this was one of the very rare patients who presented with an infantile onset. So, if your history taking does not go to the fourth generation, you might actually miss the diagnosis. So, it's important to construct a three-generation pedigree, which is also called a heredogram. So, what are the symbols in pedigree? And one chocolate for those who answer, right? So, this is simple. A circle is a female, square is a male. So, this line between the two continuous line is a line of marriage, right? Now, suppose I were to put a dotted line here, what would it indicate? I'm not getting. Yes. What would it indicate? Okay, I'm sorry, Debra. But what do you think it indicates? A line here, this is a line which is a single, unbroken, distinct line with a female marrying a male. So what do you think if I were to put a dotted line here? Anybody for an answer? Yes, there is somebody coming up. Yes, it could be an extramarital affair, a live-in relationship with somebody else, an unmarried relationship, yes. So, very important. And this obviously means that the individuals are divorced. Okay, so you have a female, a male, a true marriage, a divorced marriage, and an illicit relationship. Now, when you go down the degrees, on the left hand side, it's a Roman numeral. On the lower sides, it's the normal numeral. Okay, so it's 1 and 2 here. So 2.2 is this case, 2.1 is this case. So in that pedigree, you can actually write the, the index case which comes to you for medical attention. What is it called? Yeah. Any answers? The first child in the family with a genetic disorder who comes to you for consultation, what is that person called? And what is the name of the person who brings this child? So we have an answer coming here. Yes. So this is Thaira Bansal. That's good. That is called the proband. And the person who gets this child for consultation is called the consultant. Okay, I've sent to all the consultant, right? So this is the proband and you have the consultant. Now, a very quick guess and maybe a chocolate. Now, if I were to cross this here in the vertical line, I wish I had been doing this in iPad with a stylus. So if I cross this line vertically, what do you mean? I'm sorry, I will go back and get the answer from here. Somebody said died in utero. Not exactly, no. Died in utero would have, I'll just show you what it, no, for somebody who answered died in utero, please look at this. Here, this individual is deceased. And since you would not know the sex of the individual which is deceased, you will use this as a diamond. You won't use either a circle or a square. So if I were to cross this line, I'm still waiting for somebody actually to get the chocolate. But I don't see any hands up coming there or any question marks. Yes, there is one person who has said this. Let me see. Adoption, infertile. Okay, so I'm going to show you infertile before that so that you know this typical thing is infertility. So you have a line which joins them, and there is a one bigger line and one smaller line, which indicates that this is an infertile couple. So I think no chocolates in the first go. Yes, is there somebody coming up? Let me see. If the couple was pregnant, this would have come up at the third line. So another line would have been drawn here and you would have had this. Because in the antenatal period, you cannot detect sex. So this is very, very important. The answer to this is that you have clinically examined this child. So if in an autosomal dominant disorder, in which the parents may also be affected, but much milder than the child, if you don't put across a single line there, it will not tell the person who's looking at your pedigree that actually there is somebody already examined. Yeah, somebody did say that, but probably I had already given the answers that time, and this person who said that is again Pragya, right? So you can slash this if you have examined the mother. Now these are dizygotic twins, while if you put the central line, these are monozygotic twins. So in dizygotic, obviously this is dichorionic, diamniotic. In monozygotic, usually it's difficult to distinguish monochorionic, monamniotic, or monochorionic, diamniotic. Now, this is usually either the patient is born of undeterminate sex, like the transgender community, or this is in a pregnant situation where maybe the radiology uh, PG knows the diagnosis, but he cannot reveal it. All you can write is a diamond means you yet do not know the sex of the child, right? So these are the common pedigree symbols. And if you write 2 here, that means there are 2 female children, 2 here, 2 male children. So ideally you should write the age and also you've already written the sex and the number of individuals. Now this, whenever you shade it, it indicates that these individuals are affected, right? But these are, and whenever they are carriers of an autosomal trait, you half shade them. And these are then called, these are carriers. And you know that this is a carrier for an autosomal disorder, while with a dot, this is a carrier for an X-linked disorder. Very, very important for this. So these are individuals which are affected. Now, suppose you want to depict multiple affections. That means this patient also has diabetes, has hypertension, has migraine, and has schizophrenia. How would you depict it? Any answers in the chat box? It's how good you draw. We should tell you the answer. Just waiting for one single person. Yes. So bad for me. The classes take longer. Compartmentalize the square and circle and shade. Yes. And the shading has to be different. So you can compartmentalize it. Very good. You can compartmentalize it, put some place with dots, some place half shading, gray shading, some places dark black shading, some places red shading. And on the right hand side, you write what does red mean, what does half shading mean, what does gray mean, and what does dots mean. So you can show as many disorders as you want in this shading, but you have to write what you mean by this shading. So this means this person has died. Now, obviously, this is an affected proband, and this is a consanguineous marriage. So, by what do you understand is consanguinity or inbreeding? Anybody? So, my eye is only at the chat box. Yes, that is there. So, marriage within first relatives. Okay, now first relatives are parents or brother sister. Usually, we do not, this is called incest. Somebody said marriage, this is chavi. Marriage amongst close relatives, yes. How close? Marriage in the same family. Now, how many? I don't know. I can't see you. How many of you are Agarwals, Sharmas, Kashyaps? Yes. How many of you? If I take a rough guess, 10 of you at least would have this surname. Now, what happens in your families? You must have seen marriages in your families. So, what happens in your families? Yes. Somebody read, oh, yes, very, very good. Marriage between people with a common ancestor. Yes. Marriage between and common ancestor could be second generation family members, second cousins, or closer. Okay. So I think many of you are close to the diagnosis, but not exactly at it. So marriage between people with a common ancestor, not more distant, Pragya, than and great grandfather. So you have father. When I go to the autosomal dominant pedigree, I will show you father's father is grandfather. Now grandfather's father is great grandfather, and his father is great great grandfather. So 4 generations up or 4 generations down. Here in this situation, there are chances that if two individuals mate, they may bring an autosomal deleterious trait in both of them together, and that is called consanguinity. So, marriage between common ancestors, not more distant than a great great grandfather. That could be maternal or that could be paternal. So, quite a lot of you gave really good answers, and each class, I'm getting more and more stimulus to probably put you into a slightly tougher question and only then release the chocolate. But as yet, the chocolate is not gone. Now, this was an abortion. For example, the mother conceived immediately after the birth of a previous child. She doesn't even have time to look after the previous child, and for social reasons, she aborts. But she aborts spontaneously, will be depicted by this triangle. When you know and you do an ultrasound and you find out that this baby has the same anomaly that the previous baby had, but has yet not been terminated, or it spontaneously gets terminated, this will be an affected spontaneous abortion, while this will be an abortion which has been conducted medically because you know that this child is affected. So a single line, a dotted line, these are the lines of marriage. These are the lines of descent. This is the line for consanguinity. This is the line for divorce. This is the line for infertility. This is the line for spontaneous abortion. And this is the line when you terminate this pregnancy. For example, in a thalassemia couple coming to you in the second pregnancy, you don't know the sex. And even if you know it, you won't divulge the sex to the patients as per the PNDD Act, because if you can do the chorionic villus sampling, it'll also give you an idea what the DNA is. And you can find out whether there's a Y in the DNA or not. That's very, very easy. But you're not supposed to do it as per ethical and legal laws. And therefore, if that is an affected termination of pregnancy, you would say that this is an MTP which was done because this individual fetus was recognized to have a disease that was not compatible with life or that required significant problems with between the parents or a previous sibling of a similar kind, and therefore they should not go ahead with pregnancy. As yet, we do not have clear PNDT laws, so we follow what's actually told to us, right? So we go back and draw this pedigree. Now, just somebody, which is this pedigree? Yes, there was a question there. I can go that. I didn't understand the difference between spontaneous and affected. Okay. Now, if you do not shade the circle at all, the triangle at all, and the person aborts, that means even if it was affected, the abortion has occurred. Nobody has seen the fetus after abortion. Nobody has done an autopsy. So you don't know that this pregnancy spontaneously gave way or was affected. If the triangle is shaded and the person aborts, that means this is an affected pregnancy and was spontaneously aborted, or you are now going to abort it by medical means. If it got spontaneously aborted, you would shade it. If you did that medically, you would both shade it and cross it, indicating that a medical termination of pregnancy rather than an unexpected loss was in a situation of an affected pregnancy. I hope, Debrat, I have been able to answer your question. And my question here was, what is this pedigree? Yes, very clear. It is an autosomal. There's no doubt. Now, why is it autosomal? Every generation has affected members. So this is an autosomal dominant degree. Now here you can see there is a line crossing this. and you can see an arrow here. So basically 3.6 is the individual who came to you for medical attention, and you examined this individual. Rest is all on history. So first thing that you see is, can this disorder affect both males and females? Yes. Can males transmit it to females? Yes. Can females transmit it to males? Yes. Are males and females equally affected? Yes. So the answer to all the four is affect, and this looks like almost a vertical transmission from one generation to the other to the third one. And this is a classical autosomal dominant pedigree, with this being the proband whom you examined. And if this was the mother who brought this child to you, she would have been put as an arrow, and this would have been a C written here telling you that she has consulted you. She is the consultant for this proband whom you've examined in an autosomal dominant pedigree. So all this information you can just put by squares, circles, and arrows. And I think this is what you have been taught. You can also make this in the form of a Punnett square. The Punnett square, where the dominant allele is D and the recessive allele, that means the not non-diseased allele, is small d. The chances of mating between these two individuals. Now, usually, most of these autosomal dominant conditions are very severe conditions, and they die almost close to birth, in utero, or just after birth. And they hardly ever go to the age that they would get a partner. But there are some examples we'll show you where they grow up to a marriageable age and they either marry an unaffected mother, or if this was a father who was unaffected, he would have definitely chosen an unaffected mother. Or they marry, if they're short, they marry short. If they're deaf, they marry deaf. So the chances that the patient will be unaffected, with this D coming close to any of the Ds, there is a 50% chance that there will be somebody will be affected, and there's 50% chance that they would not be affected. Now, suppose a couple comes to you and says, look, this is my second child, right? I already have one normal child and one affected child, and I want to reproduce. I have finished my 50% chance of actually being giving rise to an affected baby. What's your take on that? Yes, anybody in the chat box. So how will you explain this? 50% chance still, yes, Nilayan, but how will you explain this to the mother? वो तो बोलेगी ना, मेरा एक 50% चांस था भैया, मेरा एक बच्चा ऑलरेडी अफेक्टेड हो गया, एक नॉर्मल हो गया, अब मैं एक और चांस लूंगी तो मेरा अब अनअफेक्टेड आएगा, क्योंकि मेरा पहला अनअफेक्टेड था, दूसरा वाला अफेक्टेड था, अब तीसरा वाला अनअफेक्टेड होगा, चौथा मैं प्लान ही नहीं करूंगी. तो आंसर क्या है आपका? Every pregnancy has a 50% chance, and chance add to this, and chance has no memory. That means each and every time it's like आपने दो जोकर और दो कोई और पत्ते रखे हैं ताश के जेब में, और आपने जेब में से एक पत्ता निकालना है. जोकर जो है वो बेसिकली अफेक्टेड है, और बाकी जो दो तीन का इक्का है, या तीन की चिड़ी है, या किसी भी कोई और नंबर की चिड़ी या इक्का है, चांस कितना है? 50%. और ये चांस 50% हर प्रेगनेंसी में है. भगवान भूल जाता है पिछली बार उसने कौन सा पत्ता निकाला था. So it's very important to tell the parent this is like this. और you can also tell the parent कि भैया एक बोरी है, एक बोरी में दो काले गोले हैं और दो सफेद गोले हैं, आपने आंख बंद करके गोला निकालना है. निकलने को काला गोला एक बार भी ना निकले, और निकलने को वो हर बार निकल सकता है. Chance लेकिन कितना रहा? 50%. So you can have 3 successive pregnancies getting affected. Still, that may be 50% because it's what God is going to do. So it's very, very important in genetic counseling to explain in the layman's language that this is the chance. Chance has no memory, and explain by simple examples, something that which he would understand without medical terminology, right? So a classic autosomal pedigree. We'll just skip this slide. Uh, most of these autosomal dominant individuals, they die in utero, and most of these autosomal dominant disorders are usually de novo. That means neither parent has that problem. And this is just a chance that this individual has developed an abnormal mutation in one of the sperms or ovum and therefore becomes affected. So, a lethal homozygous condition like achondroplasia would die in utero, while if it is a de novo inheritance, that means neither parents are carrying the inheritance. So it's important to understand that autosomal dominant inheritance can be inherited, but with disorders compatible with life. But it could be occurring for the first time as a problem in mitosis or meiosis, giving rise in that particular generation to an affected member, right? So classic examples of autosomal dominant. Here you can see the coloboma of the eyelid, right? The low set ears, the triangular face, and with this, you always looking at this, oh, this is feature Collins. While this is one of the craniosynostosis, and if somebody can have a look at the baby's hands, they appear like mitten hand. So which is this craniosynostosis syndrome? Yes, I'm just looking for, yes, good, excellent. There are people who are answering. Shiviha, you're very, very close. Acha, can explain similar to the coin toss. Harsh, yes, I agree. You can also say like it's like tossing a coin. There's a 50% chance that you will get a head or a tail. While here it is not alert, but it is Apert syndrome. So I give you the answer correct. Just a little bit of spelling change. And I am extremely pleased that all of you know what genetics is. So these are two autosomal dominant disorders. And now this is a child with achondroplasia, which is again an autosomal dominant disease. And remember, all these short individuals would like to marry short. So you can see this is the arm, this is the rhizo segment, this is the meso segment, and this is the acro. So the upper segment is the rhizo, meso, and acro. You can see that this child's here, you can see very clearly that this child's upper segment, that is rhizo segment, is short, the meso segment is okay, and the acro segment is small. So this is mesomelic limb shortening. So this is a short, disproportionately short, because the limbs are shorter than the trunk. So yesterday, for those who were there for the class, we had discussed one way of looking at short stature. One way of looking at it, and almost all, is first look at, is it proportionate or is it disproportionate? If it is proportionate, you go for estimation of the chronological age, the height age, and the bone age. But if it's disproportionate, you look at what is short. Is the trunk short or are the limbs short? So is it a short trunk dwarfism or is it a short limb dwarfism? And if it is a short limb dwarfism, is it rhizo, meso, acro, or it is a full short where it is called micromelic? Now this third, you can see a trishul here. Such type of hand in these children, here probably you can't see it this well, is called a trident hand. And you will see many of these children actually begging or on the counters and or even walking with you. So they are adults with mustaches but have the height of just about an 8 to 10-year-old. So this is a very important and a common autosomal dominant disorder compatible with life, right? Now, autosomal recessive inheritance, on the other hand, manifests if both the alleles are passed on to an affected individual. So, in only one of the allele is not enough to cause disease. So, if you look at the Punnett Square here, you have a capital R, which is a small r. Here, the small r is the R which has carrying the abnormal autosomal gene when this individual mates with another individual who is also a carrier. So imagine all of us could be carrier of 7 to 9 deleterious variations in our genome. But we were fortunate to have married an individual who did not have the same disorder. So the chances that you will actually marry somebody who carries the autosomal recessive gene is in inbred pedigrees, though they are not actually married to cousins. That's what the example is in Agarwals, in Sharmas, in Kashyaps. But let me tell you, when when these generations started, they were scientifically very, very sound. They used to leave 4 gotras from the Nani side and 4 gotras from the Dadi side. So they would ask, single के पहले क्या था गोत्र गुप्ता था गुप्ता के पहले क्या था अग्रवाल था अग्रवाल के पहले क्या था सिंगल था ये नानी के साइड से था और ये दादी के साइड से था इनमें से किसी कास्ट में भी मैरिज नहीं होगी. That means they were sound enough when this tradition started to keep the family money, to keep the family culture. They were very, very sound. The Janam Patri, which is now akin to a Gene Patri, would actually tell you that for 4 generations, the mating did not occur between affected individuals. But now, what happens? If it is the same caste, the mama says, "Main kar deta hu kanyadan." We are we have become so advanced that we have forgotten the basic principles of genetics. And here it's very, very important to understand what inbreeding and uh, this looks like. So consanguinity is between being who share at least one common ancestor, not more distant than a great grandfather. And if you marry a cousin, this is a 3rd-degree consanguinity. If there is a marriage between the daughters of first cousins, these are called first cousins once removed. So अगर मामा के लड़के के बच्चे से शादी हुई है, मामा के लड़के से नहीं, so this is a 4th-degree consanguinity or marriage between cousins, first cousins once removed. I hope this is a little difficult understanding. So first cousins, mama, chacha, masi, bua, anybody's child. That is a 3rd-degree consanguinity. But if mating occurs between sons and daughters of first cousins, this is 4th-degree consanguinity, and you also called is first cousins once removed. Once removed means either parents of first cousins or children of first cousins. They are actually first cousins once removed. So this is what the concept has to be understood. A very common autosomal recessive disorder is thalassemia. And what do you see here of the X-ray? What is this X-ray picture called and why? Yes, I have an answer coming in. Here, Ishika Gupta is correct with hair on end appearance. Yes, correct, Ishika. You're right here, and you can actually look at the hair on end appearance, and this is because of extramedullary hematopoiesis. So the skull doesn't take part in the hematopoiesis, but here the bone marrow is not functioning. The normal areas where the bone marrow should be functioning are not functioning. So the extramedullary sites like the liver, the spleen, and the bones which are non-cancerous and are not taking part originally in blood production have started producing, and that's why you get this hair on end appearance. And beta thalassemia is one of the commonest disorders that is autosomal recessive. Okay, now X-linked recessive. I showed you this obviously means this mother is an obligate carrier, right? So, what would be the chance that this mother's mother would also have been an obligate carrier? Yes, an answer there. Mm, the chipmunk faces was correct, Ria, but the question was for the skull. Somebody said 0. I don't agree. I don't know it, but if I don't know it, there is an excellent. Yes, there's an answer coming here. Let me see who this is. There is a 50% chance against Ria is correct here. A 50% chance that the mothers would have been born to a carrier. So here, rather, we would have, if it is a consanguineous pedigree, there would have been a 50% chance. If it was a de novo, there could have been a 25% chance. So in an X-linked recessive inheritance, you can have carrier daughter and affected son. So the mother who looks normal gives birth to an affected son. So here these mothers are not abnormal. They look absolutely normal, but only the sons look affected. Only the mothers transmit the disorder to the sons. The fathers cannot transmit the disorder because the fathers are giving only the Y chromosome here, but they are giving an X chromosome here. So the daughters could be a carrier. So that is exactly an X-linked recessive inheritance. So classic example is hemophilia. Now I have given you 2-3 clues here. What could be and what could not be hemophilia? So a child who presents to you with bleeding onto the skin, that means petechiae, purpura, or ecchymosis, like what you get here, or epistaxis and hematochezia, or any other mucous membrane bleeds, versus a child who comes to you with deep joint or muscle bleeding, or bleeding into the skin, liver, or the spleen, which is an example of hemophilia. Already have answers coming in before. Praniti said the first one, and Ishika said the second one. So I have to be a little partial and go with Ishika. Then yes, it is the second one. So between a bleeding disorder and a clotting disorder, hemophilia is because of a clotting factor deficiency. That could be factor 8, could be factor 9. Factor 9 is autosomal recessive. Factor 8 is X-linked recessive, right? So a bleeding disorder like von Willebrand's disease, like platelet numerical defects or platelet structural defects will present with skin bleeds, epistaxis, hematochezia, while clotting factors would present with deep joint, muscle bleeding, bleeding into deep organs, and even bleeding into the CNS. Sorry, where did I go? Yes. So here, let's go to the next slide. Now, who does this pedigree belong to? And answer within 1 second. Yes, the second one. Ishika said the royal family of Queen Victoria, right? Good. Yes, this is pedigree, and they almost all these male members had hemophilia. So, just for an example on how to remember what pedigrees are. Now, there are four or five answers to this. Can you get a manifesting female in an X-linked recessive pedigree? Usually, if we go back, we have seen that none of the females were affected and almost all the males were affected, right? So my question here is a little difficult. When can you get a manifesting female I have some answer here. Many said Queen is Victoria. Yes, the first answer is correct. This is Anisha and Tusham Srivastav. Both are saying lionization. Yes. So if by chance the normal chromosome was inactivated, one of the God is very, very fair. He says if you have two X's, I am going to inactivate the other X. I don't want a double dosage of gene on you, right? But not all the genes on the X chromosome are inactivated. There are certain genes which are still working in a allelic manner. So, yes, the answer is also if the father is affected and the mother is a carrier, correct? So that could be another example. That's Pragya again. Alicia, no, that's not correct. So we have two answers here. We have if the father is affected and the mother is a carrier, and two-person answer this question correctly. Mrityunjay, I think. No. Asta Johri, lionization is correct. And both the answers, yes, ma'am, father and mother carrier, these are also correct. But still two missing. Still two answers missing. So I got another answer here. Let me see if the answer is correct. De novo mutations. Yes, Shivika. You can have de novo mutations like autosomal dominant. This mutation may have come for the first time in, yes, father cannot be a carrier in the X-linked disorder, and Turner syndrome. Absolutely correct. So 4 answers out of 5 given. Very, very good. The child could be having Turner. The child could be inactivated X chromosome or, by lionization, or it could be marriage between the carrier mother and an affected father, right? Or it could be a de novo mutation. So only one answer left. Only one. So I had 5 answers here. All the 4 you answered correctly. Only the fifth is missing. And that fifth is a little difficult one. I've given you enough time to look at in the internet, but I would still give you a chocolate if you happen to answer the question. Yes, there's somebody coming in with some answer. Somebody, both Anisha and Tusham have written a Robertsonian translocation. I would not say Robertsonian because X chromosome is not an acrocentric chromosome. So Robertsonian translocation usually occurs on an acrocentric chromosome. Reciprocal translocation, I would still agree with. That means an X autosome translocation. So a good genetic material is neither less of DNA nor more of DNA. So if this has occurred by an accident, that a part of the X chromosome has gone to one of the autosomes, and apart from that autosome has gone to the X chromosome, and at the point of break is this gene lying where this break occurred. The rest of the genetic material is okay, but where this break occurred on the X chromosome was the gene for this disease. You could have a manifesting female as a carrier. So barring this, so the last person, I would accept it, but with half the chocolate, right? So X-linked dominant inheritance, on the other hand, looks like an autosomal inheritance, but all the female children are affected by an affected father, but no male children will be affected. So that's because male, it is lethal in utero. So those males are aborted, and the females who grow up still having one of the X's intact manifest the disease, and therefore you have an X-linked dominant inheritance. Now, name this X-linked dominant condition. So my eyes are glued to the chat box. And if I don't get an answer, I'll feel a little, it is a difficult question, but then not as difficult. You can see some hypopigmentation occurring on one side. The other side is completely spare, occurring along the lines of Blaschko, almost infecting half of the individual's trunk, limb, even the lower limb. Here also you can see it, half and half. This is another view of that child. Yes. I'm sorry, let me go back to the chat box. Yes, it is incontinentia pigmenti. That's both Mrityunjay and Shivika also tried, Shiviha also tried to say, and Dhairya. Three of you correct. It is incontinentia pigmenti, one of the commonest X-linked dominant conditions. And since it's the skin, which is a mosaic for the X-linked dominant disorder, you may not get the answer on the genomic DNA. Remember, here the condition is X-linked, but it is the skin fibroblasts DNA which will give you the answer and not the genomic DNA. So you must understand that not everything can be checked by genomic DNA for disorders which express onto the skin or onto the CNS might have a mosaic situation in which some cell lines will be normal, explaining the normalcy on the other side, and some might be abnormal, explaining the abnormality on the other side. So this was a good answer. Now, most often you get a sporadic case. What are the chances? Either disorder is non-genetic or too many genes as well as the environment affected. It could be autosomal recessive, I can't say because there is a 25% chance, or it could be a new dominant mutation. Or since it has been passed, it cannot be X-linked recessive because it would have then gone to the male. So this fifth is wrong. So any of it could be a sporadic case, and therefore new dominant mutation, you would say the least chance that you would get a baby affected is 5% or 15% for a polygenic, 25% for autosomal recessive, and 50% for an autosomal dominant. So the highest risk is 50%. You still want, we can do a prenatal diagnosis. And that's how you're going to explain. Now, you already, I think, know this. Not everything is so simple. Not everything is so straightforward. Now you have generation 1 not manifesting, generation 2 not manifesting, generation 3 manifesting both females and males, right? What? So obviously, all of them cannot be de novo. 3, 4, 5, 6. Too much for de novo. De novo never occurs again. It just occurs de novo. So what is this? The chat box is not showing anything, no color. Yes, there is some color coming on the chat box. And this is an interesting color because AR inheritance, Alicia. Could be, but can't rule that out because males and females. And here they would not have realized that they are carriers. Could, rarely. Yes. What's the other explanation? Let me see if somebody else also has another explanation. Right. So this is again, both Ria and Anisha are correct. It's an autosomal dominant disorder. No, not recessive. Sorry. So Ria is correct. It's an autosomal dominant disorder, but incompletely penetrant. What do you mean by that? You have the genotype, but you don't express the phenotype. So what you inherit is the genotype. What you look like is the phenotype. You have the genotype here, but only few of these individuals are expressing the classical phenotype. So a disorder of skipped generations or incomplete penetrance. Despite the gene, some modifier gene, some environmental factor is not replacing the father or the mother who have transmitted this gene to all of these individuals, manifesting it. So this is called, so this is a real life complication situation where counseling is going to be very, very difficult because this is an incompletely penetrant pedigree. So even if you find the genotype in utero, you cannot predict whether this child will develop the phenotype or not. And therefore, this is one of those classic examples. Now, here, what is this pedigree? Two possible answers. One is clear and the other is not. Yes, there is an answer in the chat box. It could be Y-linked. Very good. So both Alicia and Pragya, yes, it could be Y-linked because only males are passing to males. But here, look at this. If I would have not looked at this individual, this coming from the mother, I would have said, oh, missed this individual. Yes, it looks like, definitely looks like Y-linked. But then this mother is transmitting to a male. So this cannot be Y-linked. So this is an autosomal dominant with sex-limited expression. One classic example is congenital adrenal hyperplasia, in which there is virilization in a female child. But in a male child, there is no phenotypic effect. So these male children, as we discussed yesterday, just die after the age of 6 weeks to 8 weeks with salt wasting and a misdiagnosis of diarrhea, right? So the other thing is, what is pleiotropy? Pleiotropy is a single disease with different manifestations in different organs. So एक single amino acid substitution हुई hemoglobin protein में, एक ही प्रोटीन ऑल्टर हुआ, लेकिन इस बच्चे को पेन भी हो गई, किसी को स्ट्रोक हो गया, किसी को लेग अल्सर्स हो गए, किसी को ये तीनों हो गए, किसी को जॉन्डिस हो गया, किसी को गॉल स्टोन्स हो गया, किसी की किडनी डैमेज हो गई, somebody had lung damage. So one single mutant gene, one substitution, and so many manifestations. So this is called pleiotropy. So you understood. Penetrance means you have the genotype, you don't express the phenotype. Pleiotropy means a single mutation, but so many different manifestations in so many organ systems occurring between one family and the other family, and the same family also differently. So genetic disorders could be inherited. These were single gene disorders with classic Mendelian inheritance, but you could have non-Mendelian inheritance, mitochondrial genes, trinucleotide repeats, and genetic imprinting. Now I have a full half session to go, and I have already finished my time. Yes, somebody wrote that it cannot be testosterone affects the expression of an autosomal dominant disorder. Yes. So both Mehak and Ria were correct. So I would take up another slot to complete the rest of the interesting questions and answers. But if somebody is waiting to join the class, I by default should stop the class because I have a lot of good examples and a lot of good genetic disorders to show to you. So I will take an optional slot from one of the pediatrics times and complete that with you, right? So I'm sorry to keep this class almost half, and excuse me for this. I'm really happy that all of you participated, and I thank you for your kind attention. But I don't want to skip into somebody else's time. It's already 9 o'clock and I started sharp at 8 o'clock. So I promise to be with you to complete this class some other time. Genetics is so interesting. It cannot be done in a single class.